Okay. Okay, so I know there's a lot of people still joining. So we're so excited to see, familiar faces, names, a lot of urology love, but a lot of different people that are here, different backgrounds. So I'm just really excited. This is really the first sort of webinar kind of series that I'm starting, and I'm so excited. Dr. Marty Koyle actually reached out to me, I learned a lot more about him that I already knew. It's a little bit funny story because when I trained at Kaiser as a urologist, his best friend is Dr. Richard Hurwitz, who's one of my, great mentors. And I always heard Marty's name all the time because they were best friends. And it was sort of like I grew up with him too, as I went through training. And I got to meet him a couple of times, but never really knew a lot of him or his story because they were just sort of friends. So it was just so fun to kind of reunite and kind of get people from the past and just, kind of come together with some things in common and some things that we're all doing. So today, this webinar really is just a really kind of like a friendly conversation about some topics that are really important in medicine that I think need awareness, that need, just some honest discussion, some compassion. And to me, especially, I guess, as a surgeon, really a way to have some tangible things of like, well, what can you do, as a person, as a institution, as a leadership arena. And so that's really what this is supposed to be today. We don't have a lecture, you can definitely see many lectures on these topics we're going to talk about, which is, burnout, second victim syndrome, moral injury. And, there's a lot of lectures, and obviously we'll talk about data and numbers, but we really just want to talk about it as a person, as a human. So that I really hope that is what you get out of today. And just obviously, if there's any questions, please, raise your hand or put in the chat. We'll go through them and make sure we answer them. So again, people are still coming on, but maybe we'll just sort of get started. So for those of you that don't know Dr. Marty Koyle, I'm going to kind of let him kind of tell you guys more about him, where he's been, sort of his career, where he trained, and sort of where he is today, because he's definitely been in many, many places, including training in Los Angeles, been in Denver, and so, Canada and back to the States. So it's really like a fascinating story, and also just perspective of working in the United States and Canada, and how that could be different. So Marty, if you want to kind of introduce yourself a little bit of sort of where you started, where you've been a little bit, and where you are, to give a little more picture of that to the attendees.
Well, thanks, Diana, but I guess I have to apologize because I've been so many places. It may sound like I can't hold a job, and maybe I can't. I grew up just north of where Candace is living now. I grew up in Winnipeg, Canada. And, in a place like Canada, and especially the Midwest in general of the United States, you tend to stay at home, marry the girl next door, and not think about leaving. And that was sort of the way I grew up, is that, life was good. I thought Winnipeg was the center of the universe. And then I went to Europe in 1971. And I met all these Americans, and I couldn't believe somebody would actually grow up in New York City and go to Ann Arbor to go to university. Why would you leave New York City for anything? And so I started realizing, here I am, I've been accepted to medical school. I've got to see the world. And I was in a unique class in that 10% of my class was brought in for almost independent study for medical school, and we could go in our own pace. And one of my classmates and I both finished our first 2 years in a year in the first 6 months medical school. He elected to graduate early. My dad said, "You're too young. You need to go see the world." So I spent time in LA. I spent time in Boston. I spent time in London, England. I spent time in Churchill, Manitoba, which is on the Hudson Bay in Toronto. And I realized that I had grown out of Winnipeg. I was not a country boy anymore. Mm-hmm. And, I don't know if that's foreign to any of you, but I was one of the few, and 2 members of my class and I decided we were going to go to LA County because I wanted to be a trauma surgeon. The others that just wanted a big city experience. And I loved every day of being a resident at LA County. I thought I did not want to leave the hospital. 24 hours a day wasn't enough.
Oh my
It
God.
was fun. It was exciting. And then I started saying to myself, you know what? I'm going to be 50 years old one of these days. I mean, hopefully a long time from now. And maybe with my personality being so OCD, is this really the best alternative for me? Well, serendipity occurred in that they changed the immigration laws and I was forced to go back to Canada. So stupidly, I did something even more ridiculous. I went into cardiac surgery and I spent the next year in cardiac surgery and I was bored. I just felt, holy shit. This is not really as tough as what everybody says, and it's not so exciting. Trauma was a whole lot better. In the meantime, one of the groups that I had moonlighted for in Los Angeles, so in those days we used to do a lot of ER shifts, make a lot of extra money, asked, would you like to come back as chief of an ER? And I said, great, can you get me a visa to come back to the States with my hope of going back into general surgery? And they got me a green card. I crossed the border in Grand Forks to Grand Forks, North Dakota, and I called the group in Los Angeles and said, I'll be there in 2 days. And they said, no, you won't. You're going to Texas. And I said, going where? I'm the opposite of a redneck. What am I going to do in frickin' Texas? And they said, you're going to be chief of an ER. I went down to Texas and figured if I'm going to live in Texas, I'm going to buy a ranch, which is what I did, and cowboy boots, and I had a truck. And I didn't buy a gun. I still, Carmen may know some of the stories of my visit to Atlanta when they took me shooting, but they took me shooting for the first time in my life, and it was quite an experience. Anyway, to make a long story short, while I was in Dallas, I figured, okay, maybe I can get back into general surgery because Parkland, of course, and UT Southwestern had a fantastic general surgery program. And I had never done urology, didn't know what a urologist was, didn't know anything about urology, except they did a lot of rectal exams and took care of guys who couldn't pee. Well, Paul Peters, who ultimately became president of the Board of Urology and president of the American Urologic Association, gave grand rounds one day, and he talked about renovascular hypertension. I figured, holy crow. He didn't talk about the interesting rectal exam. And he said, and so I started going to urology rounds, and Terry Allen then presented the first way of looking at intersex, which is now DSD, and classification system. It was like they operate on kids. And the week after, Arthur Sagalowski talked about transplantation, and I said, holy crow. And Dr. Peters came up to me and said, are you a new urologist in town? And I said, no. And I told him everything I'm just telling all of you. And he said, boy, you're going to come spend a week with me. And after the week, you're going to want to be a urologist. And the rest is history. And so I ended up not going back into general surgery. And I decided I really wanted to do pediatrics for some stupid reason. Pediatrics wasn't much of a subspecialty at that time. And that was my reason for choosing the Brigham, because it would be going through Children's Hospital. And I was accepted into again, sort of sounds like medical school, a special urology program, because Dr. Reddick was allowed to accept one individual per year, aside from the two who would go into urology as a whole, where I would do 6 months a year in pediatric urology. So I was brought in to do 18 months of pediatric urology during my residency. So almost a fellowship during my residency. Anyway, I get there, and Dr. Reddick has said, well, next year we're changing things. We're bringing in a fellow. And it's like, oh my God, I made the decision to come here, and now you're bringing in fellows. So I'm going to be a second-class citizen. And I ended up, going on and on and on, and I finished. And ultimately, I wanted to go back to Los Angeles, being single and having enjoyed my time when I was at LA County. And Rick Ehrlich brought me on as a fellow for 1 year. And at the same time, because during my residency, I had done a transplant fellowship, I was chief of transplant at UCLA, and a program which was doing 12 to 13 transplants a year, then became a huge program. So I thought Los Angeles would be great. And as you and I were discussing before we came live was I couldn't stand living in LA as a doctor. I was living in a car.
And driving everywhere.
Driving a car. I lived on the beach. I may as well have been living in Cleveland because I saw the beach so little, it became ridiculous. And one day, in what was called a SIG alert in Los Angeles, so I don't know if any of you know what it is, but I won't go into it. My car blew up on the freeway and I said, that's it. And I had already turned down a job in Denver to be chief of pediatric urology. And I called Denver as soon as I got off the freeway and said, I know it's a lousy job. I know it's horrible, but I'm coming to Denver. And I was engaged at the time, and my fiance, who had moved back from New York to Los Angeles to be closer to family, said, I don't know if we should get married. And I said, well, take it or leave it. I mean, I know that's a horrible thing to say, but I'm going to go nuts because the freeway is driving me nuts. Correct. So I went to Denver. Denver turned out to be a phenomenal job. I took a nothing program. It's still the best mix of cases I've ever done in my whole life. I was doing transplants. I was doing a lot of oncology. There was no gray zone that urology didn't do there. So for my specialty and for what I like doing, it was a perfect place. Something changed though in 2001, and you know this is a long story to get to the first part of what burnout might be.
I think it's getting to there because it's important where we come from, what we experience.
Well, I think it
how
is
it builds, right? So
yeah, because on 2001, my son's best friend, who was on his soccer team, died of a brain tumor. 3 months later, my wife and I took the kids up skiing, and my middle child started having nausea, vomiting. We thought it was maybe just altitude sickness. Sure enough, as it became quite evident, even though his pediatrician found no neurological signs, I asked one of my colleagues to get an MR, and I was in the MR unit watching each X-ray slice come through as he was diagnosed with an inoperable brain tumor, and he died on Christmas Day, 2002. And again, I thought I was, quote, resilient. You know, I did a lot of things. I was playing hockey, I was playing squash. I had great friends. I cooked a lot, traveled, you know, life was great. But I felt different afterwards. My wife, who's a physician, was given a year off. All her colleagues at Kaiser gave her their sick time and vacation days so that she could take the year off to sort of get back in the group and take care of our other kids. My institution, it was basically, we expect you back in 2 weeks. And I just went back into the grind. And it wasn't the same, to be quite honest with you. It was a situation where, you know, people looked, or I thought people looked at me differently, if that makes sense, where, you know, if I got a little upset in the operating room, which occurs occasionally, they would say, oh, hold off. I mean, back off. He lost his kid. And, you know, it was very difficult for me as someone who had a big interest in oncology and did a lot of tumor cases to go back to the ward where my son had been treated and, you know, where I knew everybody. And again, people were nice, but I just didn't feel the same as I had beforehand.
And you had no time to grieve. I mean, just the fact that anybody expects that you're going to go back in a certain amount, whether it's a week or two, which is ridiculous, to go back and just go on like nothing happened, and not grieve and not spend the time to grieve your own loss and the family dynamics and be there for the other kids who are struggling, your wife and yourself. I mean, I'm going to call it a bit of like inhumanity. You know, that is a very pervasive thing that happens in medicine, unfortunately. And I guess, you know, we will get up, you know, into it, but it really is, you know, obviously in this such a difficult time, it really always highlights thing, amplifies what the disease is of the culture, right? Because if we were in a culture that truly was about healing or about people or humans, we would understand that, you can't just go back in a week or two, whatever time they gave you or didn't give you. And that, you just can't just go on like everything is go back to normal, because it isn't and it won't be. So I think that always sort of highlights what the problem with the cultures are. But we can kind of go on more. But of course, to me, just listening to that is like, yeah, we just go on, but you just can't go on. And when things like a death in the family, when we go through, we'll talk about burnout or second victim syndrome. When we go through that as individuals who are in a healthcare setting, what is our support? What is the humanity we bring to it and how we support each other? And I think that there is a lack of that. Now we're trying to change the narrative and really try to say, are we a culture of love and humanity and compassion as we're supposed to be towards others, like to the patients, but what about for us that are in there, and I think just your story really like shines that, because it's impossible to go back. And even 6 months, I mean, what does 6 months even mean? There's not a defined time for grieving, and especially a loss of any child. And I'm a mother, but it's unimaginable to go through that, and also to work in the same place. You saw an MRI, you saw them putting IVs, you saw them, whatever tests they're doing. I mean, it's like it really kind of haunts you. So I mean, it really is unmanageable. So I'm sorry for hearing that in the loss, because it really kind of puts a pit in your stomach. Just even years later, it's unimaginable. So obviously going through that, I mean, so we can talk about like, I mean, yeah, it sounds like definitely no support, right? So you are now in a situation where you're back to work, and it's like everybody's walking on eggshells. Should you say something? Should you not? How am I being looked at now differently? And how do I feel also differently? Because you're not the same person. And I think at that point, you kind of felt like maybe it wasn't a kind of good fit anymore to be there because of everything going on. And I think that's where you sort of then made a kind of move to then go back or go to Canada, right? Is that when it sort of you went back?
So actually, what happened is Mike Mitchell called me and said, "I'm retiring.
Okay.
I put your name in to take my place in Seattle." And I spoke to my wife about it. Meanwhile, there had been other changes in Denver. The hospital moved to a location which required me to take a car rather than run or ride my bike or cross country to work every day. And we had a change in administration. So my two partners, and we were recruiting a third, decided, we're not going to work under this new CEO. And I didn't want to build all over again. And Mike said, I'll be stepping it down. They're looking. And I made the final cut along with a really good friend of mine, and sort of, I don't want to say beat him out for the position, but I got the position.
Yeah.
And it happened. I accepted the job in 2008, and many of you are too young to remember, but that was the year that the stock market sort of crumped, and our home, which had been on the market, didn't sell. So I was moving in January of 2008, and my wife and kids, if we sold the house, were going to come and join. As it turned out, because of the market and everything else, it didn't happen, but I was living a dream life. I lived on a floating home. I lived along a bike path. I could run. Although a lot of people hate Seattle weather, I love Seattle weather. Beth Anderson, who's on this group, she and I have been talking about the ups and downs and good, bad, and ugly of Seattle Children's. But all in all, I liked the mission of the hospital, where they were going. I liked the department that I was working in, my colleagues. And then catastrophe hit again. I slipped in the cafeteria, avulsed my quadriceps on my right leg, and it took me a little over 1.5 years to walk independently. I missed work for a little bit more than 6 months. I was on disability, and I must admit, again, talking about resilience, I think I was able to survive my son, but being dependent been an active human being, and putting on 45 pounds and looking at yourself in the mirror and not knowing who that ugly person is was not too much fun. And again, it sort of came down to the situation where initially I felt there was a lot of support. It then got to the point, are you ever going to come back to work? And I didn't know if I ever could go back to work. So one of my friends, who was the chief at Sick Kids in Toronto, came as our visiting professor and said, why don't you come and join us? We have a position and we wanted you to revitalize our fellowship program. And I figured, okay, let's see what they have to offer. And went and looked at it, and I decided, you know what, I'm not helping my colleagues in Seattle. I loved living there. I loved my friends. I loved my social community. And I decided, rightly or wrongly, to leave. And having been a Canadian, I also felt strongly about the strengths of a single payer health system. When I got there, I don't want to say a lot of promises were broken, but like many people who sign contracts, you sort of figure they're all the same. They aren't. And a lot of promises, at least the way I understood them, weren't kept. But that was besides the point. Again, it was a place that a city the size of Chicago, one medical school, one children's hospital, no competition. But having left Canada in 1976, coming back in 2011, it was if I had walked out the front door, come in the back door, and people were still wearing the same bell bottoms and polka dot shirts of the 1960s and 70s and eating Swanson's TV dinners. I mean, it was like nothing had changed.
Nothing changed, yeah.
And
Except
the
you
whole
changed.
well, the whole concept too was, again, here was somebody who believed in a single payer health system and putting patients first. And it was like the VA in the 1980s. It was like a conveyor belt of patients who had no face, knew it was revolving doctors, no consistency, unlike Seattle and Denver, where I knew almost every pediatrician by face. And I knew, you'd go into a movie theater and some kid would come up to you and you'd say, hi, Johnny, how have you been doing since surgery? You knew people. In my 10 years in Toronto, I knew 8 pediatricians outside of the hospital. The kids, it was like a conveyor belt that you was seeing 65 patients a day. And Seattle, one thing I got very interested in was quality improvement and patient safety. And one thing the University of Toronto had outside of medical school was a fantastic school of public health. And one of the masters they offered was a master's of science in quality improvement and patient safety, which I got accepted into. And it turned out to be fantastic. So a lot of the things related to Lean, Six Sigma, that had been sort of part of the mission of Seattle, I was able to start to implement in Sick Kids. And then my third trauma occurred. And again, I didn't believe in burnout. I felt I've been able to make it through. I was operating again. I'd become the chief, even though I didn't think I'd ever want to be a chief again. And I was making some strides, and a case occurred, and I don't want to get into the details because it still hasn't completed, but it has led to a massive lawsuit. I can tell you it likely would not have happened in most institutions in the United States because it was an error of communication. Patient I had never met or seen before, but in Canada, there's something called the most responsible physician, where if someone was referred to you and an x-ray was ordered on behalf of you, you're responsible for that patient. And it turns out there was a misdiagnosis and I never got called by the radiology department. So I had no idea who the patient was, but I was left holding the bag.
Marty, we lost it a little bit.
My sense of personal achievement. And I started looking into it and I realized I was burned out by all definitions
and measures.
I was depersonalized. Whereas before, any kind of exhaustion I was able to get through. Someone who, today I have over 300 peer-reviewed papers in my CV. I felt I was a phony. I was the great imposter. and that this is how my career was going to end. And so for me, it was an awful situation where I stepped away. I lost confidence in myself. So, after being a surgeon who goes, volunteers in lower income countries every year, takes people with me, educates, I felt I was the biggest loser who had ever walked the face of the earth. And I was surviving. That's all I was doing. I wasn't thriving. I wasn't learning from the experience. I felt in many ways, had I been thrown under a bus, which is, what my malpractice attorneys have said. But, you don't want to blame people. I don't blame people or situations. I always take things personally and try to do something better. Again, probably the quality improvement part of my personality. Anyway, to make a long story short, I decided, okay, maybe it's time to get out of medicine. And that was my impetus for enrolling at McGill in their Master of Management program. It's an international master's in health leadership. And they sort of said, what's a guy in his late 60s doing enrolling in something like this? And I said, look, I still love teaching. I love mentoring. I love coaching. I don't know if I'm a good doctor anymore. I really don't know anything about me anymore. And I want to be able to learn and be inspired. And it started off pre-COVID. So it was in person in Montreal, which is a phenomenal city for those of you who haven't been there. And the program was unbelievable. It's sort of a master's of management is like an MBA for people without the work experience that many people who go into business administration have. For me, it turns out to be very positive because I was kept on faculty afterwards. And a lot of the things that have occurred and probably my voice in class have led to me teaching some of the programs there. One is on wellness and burnout, moral distress, and second victim syndrome. And one is in quality improvement and patient safety. And now I've been asked to be on the medical school there. Anyway, then COVID enters the picture. And again, my wife and kids have remained in Denver from the time I left for Seattle in 2008. And COVID made crossing the border just unbelievable because here I am in a situation where every time I come back from the States to Toronto, I'd have to quarantine for two weeks. I'd have to have 3 nose swabs. Ultimately, they imposed a restriction where you had to stay in a government hotel and pay $2,000 to $3,000 while you're quarantined there because of things that were going on. In the meantime, we started learning about something called moral distress because here with COVID, we actually in a rationed healthcare system, which is what Toronto or Canada had in some ways because it was a waiting list type system. We had to truly ration it. And urology being, especially pediatric urology, in most cases being an elective situation, we already had a backlog of over 400 orchidopexies. And for those of you who aren't urologists in the group, that's one of the most common operations we perform in children. And ideally, we like to do it in the first year of life between 6 and 12 months or up to 18 months of age. Our mean age prior to COVID was 3 years, 11 months. We now have well over 1,000 kids, or they have well over 1,000 kids waiting. So you feel morally that here you are trained to do no harm. And what are we doing?
Yeah.
We're harming people. Okay, I mean, we're being forced to decide who needs surgery because of something that's going on. So the social, the psychological, the spiritual suffering that we feel despite our trying to control the environment in which we work was totally lost. And I think we all have moral frustrations, okay? But eventually it gets to a point where it's injurious to us and something painful and impacts us because we have a conscience. So again, you start feeling many of the same things that I was feeling after my malpractice case, feelings of guilt, feelings of shame. Um, you feel you're bad. You're feeling that you've lost faith in other people, especially anti-vaxxers. It's a tough situation. And, I was never a religious person, but I've always been fairly spiritual in my feelings. I even lost that. I just felt, holy crow, it just seems that life piles more shit and shit on you. And we try to depend on our resiliency in order to survive.
Yeah, I think, I mean, the story is also, I mean, some of the themes kind of go throughout. And I think, I mean, obviously with the death of your son, that's different. But when you talk about burnout, moral injury, a second victim, and, all this is sort of, sometimes you don't know it's happening until it hits you in the face. Sometimes, like, you don't realize you're like, burnout is sort of like, I feel like it's a title that we could use for studies and to follow in this. But when you're in the middle of it, it's sometimes like you don't realize you're in it until like it really is like hits you in the face, or somebody else mentions it. Like, you just feel like angry all the time. You just feel frustrated, tired, guilty, ashamed. You have all these feelings. Or with second victim, which, just to kind of maybe give it a little bit more of a definition, basically is, when you become that second victim, there's basically something that happens where there is a complication, a death, a poor outcome. And, especially as surgeons, if you have a complication, yeah, that patient suffers it, but then we become the second victim, and even the institution may come out third victim. But then it's like, how do we feel when this is happening? Because you do feel the shame, you feel like you're inadequate, you're an imposter, you're not good enough to be doing this, even though you have, like I said, maybe for you, like so many peer review articles, and half of us never had or never will have, but all these surgeries in the background, all this experience. But when you're in that situation, you start kind of internalizing all these negative thoughts, and sort of becomes a really, detrimental, negative cycle. The question is like, well, what is the impact when this is happening, right? Like, what is the impact to a physician when you're burned out, their second victim, there's moral injury? I mean, I think that the impact is not only personal, but when we leave medicine, then that impacts the society. Because then to recruit a new physician, because you leave, or if somebody completes suicide or whatever, then that then is like, for the institution, cause is like at $1 to $1.5 million to bring somebody else in. Plus the impact that, especially in a place where there's not enough resources, or there's not enough physicians, specialists in that city, then there's one less to take care of the overburdened list of, let's say, patients that are waiting for orchidopexy for the surgery. Right now, it makes it worse. So there is a personal impact and a global impact, really. I mean, it's not just what happens to the person, but obviously we care about the person, because that is very important. And I guess that the thing is like, so I mean, what would you suggest? And I know you in your master's, that you did your thesis, and there's some research you've done that really talks about kind of ways to kind of do it on a personal. I really like that you sort of broke it up into 4 pieces. So you sort of did a personal of how to get through this, but burnout, moral injury, second victim syndrome. There's like a system, and there's peer support, and there's a leadership component. Because I really do think without leadership, this is not going to be fixed. And it's not just a personal thing, like you just got to be more resilient or get coached or this, because that's just plugging one hole of the dam, and the dam has many holes. So just putting on one person or the physician is not, we're kind of victim blaming. But there's definitely are things that we can do as an individual, as a collective, and as a leadership that can definitely help. So, and I think for some of them, and the talks that you've given on this, and your papers that you've done, you really have, there are some common themes. Like, I think for both, a major component is just awareness, right? Like, I think that's for both, a burnout is having an awareness that is happening, or to either yourself or a colleague. Peer support for both of these, I think, are really important, right? Like, you're not alone. You're not the only person that's had a medical error. And there was a really nice part of one of your talks that said that 90% of all U.S. and Canada physicians have experienced a medical error that they've done, right? And what was interesting too is that medical errors are the number 3 cause of kind of death, and followed by cancer and what was the other one? It was cancer and trauma. So, it's a big part of death. It's a big part of like what happens, and we're not alone. Like we've all, if you're a physician or you've operated, you've had complications, you've had made errors as well. But you're not alone. But what happens is we internalize it, we feel guilty, we feel shame, we feel like we can't do this anymore, and we may leave. And you had a very nice stages of second victim, what they go through, which I thought were really important. Maybe you'll touch on those too, but if you can kind of talk about burnout and or second victim, and kind of give some personal and safety and peer support and leadership things that can be done, I think it'd be helpful for people to just have some awareness. Because I think, when you're in the middle of it, you have no idea you're in the middle of it. And then when there's a bad outcome or there's a lawsuit, I mean, you just feel like you want to put your head in the sand, and you don't want to crawl out of like your sheets, right? And I think what's really important to get out of it to thrive and really continue is peers, as awareness, peer support, and hopefully some institutions that have programs to really help, and not just to say like, oh, we'll keep on going, like go back to work on Monday, let's see how it goes, because it doesn't go very well. So if you can touch a little bit on these, I think that'd be helpful for some of the people that are listening.
Well, I think it's really unique, Diana, that most of us, regardless of specialty, we learn basic life support. We learn, and we see someone fall down on the street, and what do? We do the ABCs and CPR as necessary. But what do we do if we know someone's been involved with a serious adverse healthcare event? I mean, we tend to walk by them because we've been taught to suffer in silence. Mm-hmm. We've been taught that we are Superman and Superwoman, which we aren't. We're human beings, but yet it doesn't matter whether it's the press, whether it's the legal system, or even in our own specialties, we're still suffering in silence. That's the reality. And I think we have certain parts of our personality that we have to look at that make us who we are and what we are as physicians. We tend to be thorough. We tend to be committed. We tend to want to stay current and realize that there's a bunch of trust put into us. Mm-hmm. But at the same time, are we really balancing that in an adaptive fashion with our allocation of time to families, to friends, to everything else? Is some of the responsibility that we inherit or is put on our shoulders, can we control it all? Or is it really beyond human expectation to be able to do something like that? And what about as we try harder and the bar keeps getting set higher and higher? One day it's epic. One day it's doing this. Mm-hmm. You're doing more and more work. You're working harder, not smarter, in many situations that put us into the unusual situation. And then if you have a situation, so getting back to leadership and things that you brought up, it's been shown 90% of us have committed a medical error or admit to it. And if it isn't 100%, we're bullshitting the other 10%, because everybody makes errors. We're human.
Correct.
But if you make an error within an institution, a healthcare organization, the sad thing about that, more than 90% of physicians who have been involved with a serious safety event report no support from that system. Mm-hmm. That's leadership. That's leadership both on our part as well as the institution, because we're not very good at being led, to be quite honest with you. And most of us, and I don't like categorizing people, but and selfish is a bad word, but we tend to care about ourselves. Okay, we want to do financially well. We want to make sure we're okay, but we're not looking at the big picture as to what's happening and the things when things go awry, where our leadership skills need to be developed in order to prevent them or to change the system so that institutions realize that we're not some people who just have to be managed all the time, if that makes sense. Mm. And I think the thing that's very interesting is if we take a look at serious errors, serious safety events, as opposed to minor errors or near misses, they all lead to the potential for increased anxiety and future errors, all of them significantly. They all lead to decreased job confidence. They all lead to decreased job satisfaction. So do you want me as your surgeon to not sleep at night?
Correct. Yeah.
Do you want me to sit at home and worry, oh my God, my reputation has been sunk after putting 40 years into what I'm doing? So the reality, you brought it up already, in order to replace physicians, it's costly. It costs somewhere between 1.2 and 1.5 million dollars to replace a physician. And I've often asked people that I lecture to, if Alex Trebek was still alive on Jeopardy, and he said, what is the question for one medical school class per year? One medical school class per year tends to be the number of physician suicides in the United States, about 400 physicians suicides per year, which is far greater if we look at males. And I know the greatest number of people within our conversation today are females, but as now that females are have surpassed males in medical school, the data is going to be interesting as it accrues. But if you take age-matched controls of successful, well-educated males who become physicians versus, let's say, an MBA or an attorney, the number who die by suicide is way on the other side of the bell-shaped curve. It's so far to the right, it's pathetic. Accidents tend to be far higher in people who in male physicians than match controls, and even strokes, believe it or not. So does it have something else to do? So I ask everybody in the audience, what would you do if a colleague around you made a mistake or was involved in a serious safety event? What do you think the organization would do, and what do you think they should do if someone makes a mistake? So I think the first things, I mean, we've talked about the 6 phases, or you brought it up a little bit about the trajectory essentially of second victim syndrome and moral entry. And the first thing that occurs is something called chaos, where, holy crow, how did this happen? It's something where you figure that this is unbelievable that it occurred. And then you become reflective to some degree. You ask yourself, did I miss something? Could I have done something a little bit differently? And then you start worrying about yourself a little bit. It becomes, oh my God, what will others think about this? This is sort of your personal integrity, which leads to the toughest part, is the part of the Inquisition. How do I document what I did? What's going to happen next? What's going to happen from a litigious situation? And finally, we hit, hopefully, a point where we seek emotional first aid. So we have to wait rather than someone intervening earlier in one of those other 4 phases. Is this going to be our legacy that defines us throughout? So that leads to 3 different paths on the road. And I sort of said that I'm surviving. That's all I've done. But the other ones are dropping out completely, which I thought of and didn't do. And I've certainly tried to thrive, to learn something from what happened to me. And maybe I have, because at least I'm helping others to some degree. But I don't think it's made me a better doctor. If anything, I think I'm a much more cautious doctor. I order more tests. I'm more petrified about crossing T's, dotting I's. And I'm an asshole sometimes when people don't do their share of work. And because we're relying on people as a team today in medicine, it's not the most responsible position, in my opinion. So the father of modern quality improvement is a guy called Demings, William Edward Demings. And he basically said at one time, the current system in which we work is perfectly constructed to get the results that we're getting. And I think medicine, like any other, quote, industry, falls into that group. So what we have to do is resiliency is important, but it only gets you so far, okay? And I think we can talk a lot about, exercise and yoga and the right diet and this, that, and the other, and hopefully do things that increase our happy chemicals in our brain. And but it's important to realize that when a medical situation occurs, a severe moral distress, we want to talk about it. There has to be disclosure and apology, obviously, that occurs early. We want forgiveness. We want something that's in moral context as we're dealing with imperfections in ourselves as well as within the system. So we have to look at a system focus on patient safety, not just our own focus on what we do. And, you know, things like EPIC or whatever are supposed to reduce the number of holes that align in what's called the Swiss cheese model, but they haven't. I mean, they've been there primarily for billing and coding perspectives. We haven't followed other what are called highly reliable organizations like modern day commercial aircrafts or even nuclear plants, which historically, when disasters happen, have been terrible, but the number of incidents continues to decline. We haven't done a good job of medicine, and our risk to ourselves and to others continues to be infinitesimally high compared to other highly reliable organizations.
Do you think that's a culture problem? I mean, because obviously medical errors continue, physician suicides continue, burnout continues, and there really is no change. I mean, saying that you're going to have yoga at noon from the organization standpoint doesn't do anything, or having a wellness officer as a check mark. I mean, does that do anything? Has it changed anything? I don't know. I mean, do you think this is an organizational issue? Is it just a whole culture of medicine? Because again, it's not just the leadership, but is it how we, because when something happens, like, I mean, of course, if you are the one that has the complication or a bad outcome, of course, you can seek support, but like, what about the rest of the people? Like, what about the colleagues, right? I mean, where are they stepping in? I mean, we all kind of have to have a shared responsibility. Like, how are we supporting them? Or how are they supporting us when that's happening? Because I think people sometimes just say, oh yeah, that's terrible, and we'll keep on plugging in, and or they're afraid to kind of approach you like, oh, is he okay? Does he want to talk about it? Does she want to talk about it? So people just sort of walk on the eggshells again, not knowing what to do. So, I mean, what would you tell people when they are in a bad situation that they're in? What should they do? Should they like an informal support? Should it be a more formalized? I think every program should have one. And I think in the chat, somebody put, our system has a program called HOPE, Healing the Emotional Lives of Our Peers. Train peer supporters to help people cope with these adverse events, and obviously can escalate to more professional help when indicated, which is amazing. I mean, Candace, maybe you can tell us more about this, because I'm not sure, where I work, they have it. If they do, who knows? I mean, is it hidden? I don't know, but it's not something that is, readily plastered everywhere, that there is a support for physicians. And I think also, whether it's a complication or just burnout, I mean, things that have been proven by research that can decrease burnout is peer support, like having informal meetings where you meet not with the admin, but just physician to physician. And you just maybe every couple of weeks, you just meet with your group to kind of discuss things. And it's not like, oh, what do we have to do for the group as the medical, but just like the humanity, like, what are we doing? What problems are coming up? But just really having support so people can feel safe, like saying like, oh yeah, this case went bad, or I had a hard case, or, maybe a complication happened, and you really can find that peer support. Because I think peer support is so important to help you realize you're not alone. There's not something flawed about you, that because errors happen to all of us, and even burnout happens to a majority of us for many reasons, right? But you're not alone. And I think having that peer support is important, and also having the self-compassion, which is something not compatible sometimes with the medicine, a structure or a training, because we're trained to be perfect, because everyone wants a perfection, a perfect surgeon at the top of their game, a perfect pediatrician, but that's just not reality, because we're human. And when you let go of that, still striving to do the best you can every day, but realizing we're not perfect, we all make mistakes of all kinds, and then we're human and you have self-compassion, it just releases all that sort of burden and negativity. You can just be lighter knowing like, I'm just human, right? I make mistakes all the time. And it's not a mistake, like it's a mistake if you don't learn something from it, right? Like whether it's like, you put the wrong Zoom time and it's something simple or something bigger where somebody could have been harmed, right? We can all learn something for next time without being crucified about it, right? Because a big part of medicine too is we have these M&Ms where you would think we would learn from these errors or things, but we're kind of crucified in these, right? It's like we shame you, we blame you. You're kind of there standing like, oh my God, and then people criticize, and not in a kind of loving, compassionate way where we can learn and move forward. So I think there's always like this underlying thing where, we can do a little bit better how we show up for others, right? And have compassion and live in a place where we have compassion for errors, whether they're medical or personal, because we're just human, right? Like if we have that conversation and we keep having that narrative that we are humans, I think, it can start shifting in people slowly that we just are humans.
Well, I think you're absolutely right. And I think, Candace is alluding to hope really stems from that institution's leadership, to be quite frank with you. I think that if you take a look, a lot of what's been written about burnout and support, not only in us, but those below us who are being educated within the medical system, our medical students and allied health and everybody else. Tate Shanafelt, before he moved to Stanford, clearly was the leader in this field, and Colin West and the others who have taken over have continued to pursue it. But John Noseworthy, who was the CEO, he along with Tate Shanafelt wrote a paper, I think in 2017, really wrote how important it was for leadership to be involved and to realize, again, within the context of a highly reliable organization, that human error occurs. That's part of us. It's also a result of the system and the behavior choices that are part of the culture within the institution as well as ourselves. That's different from at-risk behavior, where we may take a believed risk, which was thought to be negligible or justified, or something that's a heuristic that we use, something that we commonly use that's a shortcut to do something, and it doesn't work out. That's at risk, but those sorts of behaviors probably need more coaching than they do consoling compared to the human error.
Correct.
On the other hand, there's true reckless behavior, and reckless behavior is when you intentionally or recklessly are indulged in something. And that's where we do have to punish people. We can't give everybody just a pass. Some people have to go to the principal's office, and some people don't belong in that school permanently.
Correct.
So I think when we go back, Lucian Leap, who was at Tufts and the floating hospital in Boston before he ended up at Harvard School of Public Health. But in 2009, he testified before Congress, and basically, I can't remember the phrase completely, but he said that the greatest impediment to error prevention within medicine is that we punish people for being human and making mistakes. Mm-hmm. And I think if you take a look again from Boston, the Institute of Healthcare Improvement, they've always advocated the Triple Aim, which is really, the patient experience, population health, and with the attempt at reducing costs. But what they left out was the importance of the team who takes care of those individuals in order to take care of that triangle, which has led to the concept of what's called the Quadruple Aim, and that's the care team well-being. So our goal is 1 is not 0, and 0 should be our goal when it comes to harm. And we have checklists, we have this, that, and the other. Nothing is perfect. So to me, when we look at the institution, the leadership, everything else, we have to have that commitment to patient safety, which starts at the top. We have to realize that there is a team, not just an individual. We have to have.
We lost Marty.
Isn't good. Is there a better way to do it? So there's no such thing as good enough in medicine. There's always something better. And that's why, again, I'm probably attracted to quality improvement in patient safety. So getting back to what Candace brought up about hope, and Carmen was in Atlanta, where they instituted the peer-to-peer program, which Kurt Heiss, a colleague of mine, was instrumental in. But the question is, why do we allow people in isolation? We know that if someone has breast cancer, prostate cancer, all sorts of different cancers, there's support groups that get involved early to help people through their journey, no matter how bad it may be. And Albert Wu, who was the person who coined the term second victim syndrome, was really one of the cheerleaders, along with Joe Shapiro, who was at the Brigham and is now at Mass General, in leading peer support as being an important component in dealing with second victim syndrome, and today also moral distress. And with these teams, it's not necessarily your friends, it's not necessarily somebody you know, but it's somebody trained within your institution who, instead of we as untrained individuals thinking, oh, he or she probably wants some time to process everything, understands that really what we might be thinking is, I feel so isolated and alone. I actually need someone. Instead of somebody just thinking to themselves, I don't want to make him or her relive that event all over again. What's really going on in that individual's mind is, I think about the situation all the time. It's omnipresent. It's happening all the time with me. I made a mistake because I'm a bad doctor or a bad person, instead of understanding that I made a mistake because I'm a human being. So a peer support is a very powerful tool to be used within a culture. And so the thing that's clear, that's important is, one, there has to be awareness training for all of us as physicians to understand that we can ask for support if it's there, for institutions and leadership to realize the importance of having those peer supporters, and for those peer supporters to have enough training to realize that, holy crow, if shit is really hitting the fan, who do I help this person see?
Yeah, and refer out, a second referral.
Yeah, so, and it's really anonymity that's terribly important in this situation too, because you want this to be done in confidence by individuals in peer support who understand the context, who realize that this is invitation to allow them to talk about the event, not in detail, but just to let them talk. Well, you're a good listener, or what's called a curious listener, and understanding what's going on while they reflect, and to get them to really reflect themselves on their own coping skills. What have they done in other situations in the past to deal with bad events? You know, their mother's death, their dog having his leg chopped off, whatever it is. And then being succinctly able to summarize the events to make sure you're hearing what they've been saying, and allow them to understand the resources that may be available to them. So lastly, again, I think, you know, we're almost at our hour, is that malpractice occurs. Okay, second victim syndrome occurs, moral distress occurs. They all are problematic. And getting back to Noseworthy's and Shanafeld's paper, it's really imperative from a leadership perspective to acknowledge, to assess the problem, to implement targeted interventions, not only with the individual, but within units and teams, to try to improve the situation, to try to align values and enhance the culture and the ability to communicate with one another. And there has to be funding to support that. I mean, that's the reality, is that our institutions can't just provide lip service. There has to be some coin involved with it as well. So yeah, there's a lot of ways to approach this. There's lots of books. I think The Attending by Ronald Epstein's great. There's a book, I think, by Dyke Drummond on Stop Physician Burnout, which is great. There was a wonderful piece in the New Yorker in May on burnout, one of the most hilarious articles I've ever read, the way it's done, really well worth reading. But I think what we have to realize is that leadership does become a management, and that's why it's imperative for all of us to speak up. We have to work together to get the important things done. So I think that we are at crossroads. Burnout is certainly a pandemic pace, but things that lead to burnout, or burnout can lead to worsening of other things like second victim syndrome, moral distress, or whatever. We have to realize that they're there. They ain't going away. Life is difficult. There's a lot of challenges, but the only way that for us to do better is to realize there is a better, and work with one another to enhance situations that have or are occurring.
Yeah, absolutely. So, I mean, yeah, I think awareness is number one. I think talking about it, like leaving this mindset of like, we never speak up, we just, keep plugging along. I think it's really important that, have the mindset of a 3-year-old, like the why are we doing this? Why are we not doing this? And I think when you approach life like that, really like just starts to question, like, is this the right way to do things? And I guess we think about that when we're trying to discover some new magical drug or a better way to do surgery, but let's think about that in how we approach every day, what things we accept. Because I really do find that our rates of burnout, second victim, complete suicide are just things that should be really unacceptable, that we shouldn't just think like, oh, that's just life. We just keep going and we keep plugging along because we're busy physicians. Just as a little takeaway, again, peer support is so important, whether you do an informal thing, whether you do a more formal in a leadership scale it to really help and support each other. If it's not an institution, maybe bring it up. Maybe a lot of people on this call are in a leadership setting where it can be brought up, whether you're in like a chair of something or something else, like start bringing these issues up, because again, they are not going away. We can do better. If you're going through this, again, just reach out to somebody you trust. I'm sure there's somebody you can find you can trust, because we're not, alone. There is hope. I want to just make sure people know there is hope for all this. You can get out of it with support. Sometimes you have to step outside for a little bit, step out of medicine for a little bit. That's okay. Come back. But, we just can't keep harming ourselves and surviving, and we got to be thrivers. So I want to thank everybody that came. I don't know if there's any questions, we can do them quickly. I also want to make sure that if somebody wants to reach out to you, Marty, how can they find you? Is it like LinkedIn, Twitter? Where do they find you?
Yes. So I'll put my email into the chat box.
Yeah, so people want to like reach out, or you can talk more in detail. I know you have some incredible talks about this, and research you've done, and a lot of the research and programs you did with your master's was coaching other students and trainees, and coaching was a big part of what you are doing with them, and just bringing the awareness, showing that there's resources, and coaching and thinking about mindset is so important. So if anybody, again, has anything we can quickly say, there's the email, but also LinkedIn. You can find Marty, Twitter. I really appreciate everybody coming. Hopefully just realizing you're not alone, very common. There are resources, there's good books you can start, but also, start with the personal, start expanding to what are we doing at your own institution to really start the conversation and do programs that really are valuable and not just lip service.
So I think, Carmen in her comment made a couple of great points. I think trying to achieve zero harm is I think a wonderful goal for especially those of us in surgeon. Is it achievable? Not really. I mean, because there's other factors besides our skills and besides the system that cause bad outcomes. So the reality is, yes, we can continue to do things that promote better care. And I think the majority of this does depend on true open conversation, and stopping the line if things aren't rolling along well. I loved your comment about near miss conferences, which are probably much more educational because we go through them all the time. And again, that they still impact us tremendously. When we do something, we second guess ourselves, and that happens to us the next time we're there. And there has to be, I think it was you, Diana, who brought up the culture of shame and blame. We got to get away from cultures of shame and blame. It's got to be, how can we make sure this doesn't happen again? Certainly with the most serious events, what can we do within the systems that allow us to not allow the holes within the Swiss cheese to align? And, I think many of the other comments, that Seema and Yash made are very, very true. I wish we all lived in a perfect society and we were perfect human beings, but you know what, it'd be pretty boring if that were the case too. Nobody can be perfect, but we can certainly try to be better every day, and to defuse things, and like they do in the military, or after an operation. Now again, we do not only have a timeout before surgery, we also should discuss the events of the operation, take photos, do whatever we need to do to try to say, what can we have done better? How can we get from this to this? How can we have done better, even if we didn't cause harm or have a near miss? How can we do things better? That's what it's all about. It's not accepting your culture as being, this is good enough, this is my institution, so it must be the best in the world. I think most of us at times have been very angered with our institutions, but suck it up, because that's what we've been trained to do. We're good.
I think it's like the compassion that we're not perfect, the compassion that, we're human and errors can happen, but we can, achieve, try to strive for best, but also is the ego that comes in, right? That the ego sometimes gets in our way too. So we have to just have a growth mindset, because if you have an ego, it means you're perfect. You can't ever be better because you're at the best institution. But when you remove the ego and realize you can accept feedback, you can grow, how can we make things better? Even when there is no harm, no error, that always keeps you in a growth mindset to just be better. And then hopefully, downstream, down the road, not get to those errors because we improve something, even though it was good, right? But we could always improve with everything. So anyway, thank you so much. I want to end in that. Thank you everybody for coming, and hopefully it was helpful. There was, again, some good points that you can do yourself, some good book recommendations. Reach out to Marty. He is like a wealth of knowledge on this, and just so kind to share his stories and where he's been and the things that he's gone through. I hope you just come out with this, that we all go through it at some point or another, but there is support, there is hope, and please just don't lose hope, and just reach out is so important. You're not alone. Okay, so thank you so much, everybody. Have a fantastic night. I'm so blessed you guys all came and we're here. Thank you.
And to anybody who's Canadian, who's still on, happy belated Thanksgiving.
Oh yeah, yes.